I think still many more are yet to join. So we'll wait for some 2 minutes. Let everyone finish joining. Okay, let me start with the class. Uh, so today's my topic is about the chronic rhinosinusitis. Last class, my colleague Dr. Soumya has discussed about the acute rhinosinusitis, its causes, its clinical features, and its management. She has been discussed. So today, let me discuss about the chronic rhinosinusitis. Got it? So coming to the outline, I'll be discussing about the introduction part, the classification of chronic rhinosinusitis, the epidemiology, the sinus physiology, the microbiology in chronic rhinosinusitis, that is CRS, etiology and its predisposing factors of CRS, and I'll be discussing in detail about the individual etiology, and also I'll be discussing about the individual sinus infection and their management. So coming to the introduction part, what is rhinosinusitis? Rhinosinusitis is an inflammation of the mucosa of the nose and the paranasal sinuses. So according to the Task Force of Rhinology and Paranasal Sinus Committee in 1997, it has been suggested that there is almost always an involvement of the nose in all the inflammatory sinus conditions, and therefore it is termed as rhinosinusitis instead of mere sinusitis. So here in the picture, you can see the healthy sinuses on the right hand side. where you can see the healthy frontal sinus, the healthy sphenoid sinus, the healthy ethmoid sinus, and the healthy maxillary sinus. Coming to the left hand side, you can see the inflammation with the mucus filling the sinuses within the frontal sinus and also within the maxillary sinus. That is, this is the inflamed mucosal lining of the sinuses. Along with that, there will be a pus collection or the mucus collection within this sinuses. Okay. Coming to the classification, based upon the duration of the rhinosinusitis, it is being classified as acute rhinosinusitis, subacute rhinosinusitis, chronic rhinosinusitis, and recurrent rhinosinusitis. So acute rhinosinusitis, it is being termed if the duration is of less than 4 weeks. So it is once again subdivided into viral rhinosinusitis and bacterial rhinosinusitis. And what is subacute rhinosinusitis? Subacute, if the duration of the rhinosinusitis is lasting between 4 to 12 weeks, it is termed as subacute rhinosinusitis. And coming to the chronic rhinosinusitis, if the duration of the rhinosinusitis is lasting for more than 12 weeks, then it is termed as chronic rhinosinusitis. And this chronic rhinosinusitis can be present with the polyps or it can be present without the polyps. Okay. And recurrent acute rhinosinusitis, it is termed as 3 episodes of rhinosinusitis in 6 months or 4 or more than 4 episodes of acute rhinosinusitis. Okay. So coming to the epidemiology of the chronic rhinosinusitis, it is affecting about 10 to 15% of the adults, and its prevalence, it is about 10.9% without the nasal polyp, and it is about 2 to 4% with the presence of nasal polyp. Coming to the chronic rhinosinusitis with nasal polyps, they occur more frequently in what kind of patients? It occurs more commonly in the patients with asthma and also with the patients in the patients with aspirin insensitivity. It occurs in the patients with cystic fibrosis. It can occur in the patients with Church-Strauss syndrome and also with the Cartagena syndrome. And the incidence of this nasal polyp will be higher in men than the women. So one thing what you need to know about in the pathology of the sinuses is, before that you need to know something about the osteometric. So before even discussing about the pathology or the pathogenesis of the rhinosinusitis, one thing what you need to know about is the osteomeatal complex. So this is the region where it is being marked in the circle is the region of osteomeatal complex, and this is the region for the ventilation and the drainage of the maxillary, frontal and the anterior ethmoidal sinuses. Okay. If this osteomeatal complex is blocked because of any pathology like anatomical pathology or functional abnormalities, then there will be no ventilation. There will be poor ventilation of the frontal sinuses, maxillary sinuses and ethmoidal sinuses, and the secretions of these sinuses, they tend to collect within their respective sinuses, and this will act as a nidus of the bacterial infection, resulting in the sinusitis. Okay. The most important thing what you need to know about is about the osteomeatal complex. It is the region for ventilation and the drainage for the maxillary, frontal and the anterior ethmoidal sinuses. So coming to the sinus physiology, the sinus cavities, it is air-filled, lined by the pseudostratified ciliated columnar epithelium with the presence of goblet cells, and the cilia which is present within the sinuses, they sweep the mucus towards the osteomeatal opening. So whenever there is an obstruction of the ostia, it can result in the mucus impaction, because of which there will be decreased oxygenation. Because of the decreased oxygenation, there will be a creation of the anaerobic condition, and this results in the collection of the purulent secretions, which favors the growth of bacteria, and again there will be a decreased air pressure, and this decreased air pressure can result in the sensation of pain and the pressure within the skull bone. So coming to the microbiology in the chronic rhinosinusitis. In children, the most commonly affecting organisms are the anaerobes. It is the Haemophilus influenza, Streptococcus pneumoniae, Streptococcus epidermidis, and Staph aureus. And in adults, the most common organisms that are infecting is the Streptococcus species. Next is the Haemophilus influenzae, Pseudomonas aeruginosa, Staph aureus, and the Moraxella catarrhalis. Okay. And it can also be caused by the nosocomial gram-negative enteric species like Pseudomonas aeruginosa, Klebsiella pneumoniae, Enterobacter species, Proteus, and Serratia. And chronic rhinosinusitis with nasal polyps are always affected by the polymicrobial aerobic and the anaerobic flora. Coming to the anatomical classification of the sinusitis. So depending upon the anatomical classification, the sinusitis is once again divided into maxillary sinusitis, ethmoidal sinusitis, frontal sinusitis, and sphenoidal sinusitis. So when is it called multi-sinus involvement? When more than one sinus is involved, then it is termed as multi-sinus involvement, and the sinusitis can be unilateral or bilateral, and it is termed as pansinusitis if all of the sinuses are infected. And there is two more terms known as open sinusitis and closed sinusitis. So what do you mean by this open sinusitis? If the pus, if at all it's present, and if at all it's able to drain through its natural ostium, then it is termed as open sinusitis. And closed sinusitis, if the pus is not able to drain through its natural ostium, which can cause a severe symptom and leading to the severe complications, then it is termed as closed sinusitis. Coming to the non-infectious factors which are important in the pathogenesis of the chronic rhinosinusitis are patency of the sinus ostia. The patency of the sinus ostia is very much important so that the ventilation and the drainage will be balanced equally, and nasal airflow should be proper for the proper ventilation of the sinuses, and the mucociliary activity. The mucociliary system should be very much equipped, because the cilia, it should be able to sweep all the secretions that are penting up within the sinuses. If this ciliary abnormality occurs, then it does not clear the drainage of the sinuses towards the meatai, so that the secretions they tend to collect within the sinuses, resulting in sinusitis. And immunocompetence, the immunity in the person should be very good, and nature and the quantity of the secretion should also be very good. Coming to the etiology and the predisposing factors for the CRS, that is chronic rhinosinusitis. First is the infection. It could be because of the viral infection, bacterial infection, parasitic infections of the neighboring structures like pharynx and the upper teeth. Next is the traumatic infections, any maxillofacial injuries, any foreign body lodgement, any surgical or nasal packing without the antibiotic coverage that can result in chronic rhinosinusitis. And in patients with hypersensitivity like allergy, IgE mediated and non-IgE mediated hypersensitivities, and aspirin hypersensitivity with asthma, polyps, and vasomotor factors. And other predisposing factors are the environmental factors like cold weather, wet climates, and overcrowding, and any immunodeficiency predisposing factors like it could be congenital or acquired. Endocrinal predisposing factors, that is the diabetes mellitus, which is one of the immunocompromised condition, rhinitis of the pregnancy, and hypothyroidism, and mucociliary abnormalities like cystic fibrosis, primary ciliary dyskinesia. And any mass, like for example neoplasms of the nose, paranasal sinus, and nasopharynx, and any retention cysts, antroconal, and the ethmoidal polyps. These are all the predisposing factors for the development of the chronic rhinosinusitis. And one more thing, immune or idiopathic factors like granulomatous diseases of the nose, vasculitis, pemphigoid, and next coming to the pollution, where there is a chronic irritation of the nose and the paranasal sinuses from the dust, from the smoke, and structural defects like the DNS, which will cause poor ventilation of the sinuses. Again, same thing with the synechiae, where it will cause the poor ventilation of the sinuses. Cornal atresia, sorry, I have typed it as cornal agresia, sorry for the spelling mistake. It is cornal atresia here. ATRACA. Cornal atresia and osteometal complex abnormalities can result in poor ventilation of the sinuses, resulting in sinusitis, and miscellaneous like lifestyle factors. Coming to the clinical features, duration. Chronic rhinosinusitis, as I have mentioned before, it is diagnosed if the patients are having the symptoms for more than 12 weeks duration. And important predisposing factors you should be knowing. An important thing what you in the clinical feature is about the nasal obstruction, which is the most commonest presentation in the sinusitis, which will worse on lying, and it affects the depending side of the nose. And the patient will also be having the nasal discharge and post-nasal drip, which is mucoid or mucopurulent, thick and viscid in nature. The patient here in the chronic rhinosinusitis will be having a constant desire to blow the nose or to clear the throat. Okay, and headache will be present, and swollen turbinates, especially with middle turbinate, if at all it's impinging on the nasal septum, can result in the severe headache. According to the American Academy of Otolaryngology, head and neck surgery, the diagnostic criteria for the chronic rhinosinusitis is as follows. The presence of at least two of the following cardinal symptoms for at least 12 consecutive weeks, like nasal obstruction, nasal drainage or nasal discharge, facial pain or facial pressure, hyposmia and anosmia, and with the objective evidence on the physical examination, like for example, mucopurulent drainage, edema, polyps in the middle meatus, and with the radiography showing the opacity of the sinuses within the computer tomography. All these are the diagnostic features to define the clinical features of the rhinosinusitis, that is the chronic rhinosinusitis. So let us discuss about the individual predisposing factors of the chronic rhinosinusitis. So whenever there is a mechanical obstruction, so in this diagram you can, on the right hand side you can see the normal sinus physiology, where there is the this is the osteometal complex where it is not affected, and the air which is entering into the nose is easily giving a good ventilation to for within the sinuses, and there is no collection of any pus. But whenever there is an anatomical or pathological obstruction, like how we are seeing in case of left hand side, there will be impaired mucociliary clearance, because of which there is an inadequate drainage within the sinuses, and there will be a stagnation of the secretions within the sinuses, which results in the persistent secondary infection. So this is the pus collection where you can see within the maxillary sinuses because of the improper ventilation and also because of the improper mucociliary clearance. And this can occur if there is any mechanical obstruction near the osteometal complex area. And focal infections. Focal infections can be because of the rhinogenic, like any nasal infections, because of the viral infections. It could be either bacterial infection or parasitic or fungal infections. And adenotonsillitis, any infections within the adenoids or tonsils can also act as the causative factor for the development of the sinusitis. And any dental infections, like infections of the molar 1 and molar 2 teeth, and also any extraction of the these teeth can also favor the infection within the sinus. And any traumatic causes like injury, surgical, it could be surgical injury or paratrauma, hemotrauma, can lead to the bacterial infection, which results in the development of the sinusitis. If at all there is any mucociliary clearance abnormality, like for example primary ciliary dyskinesia, like Cartagena syndrome, where there will be an abnormality in the ciliary mobility, disturbance of the ciliary beating and immobility, which is seen in case of Young syndrome, and it can also be because of the abnormal thick mucosa, and it could be secondary to the upper respiratory tract infection. All these can result in the development of sinusitis. And any allergic causes, like any allergy, it can result in the mucosal edema and the hyperplasia, which is associated with the blockage of the ostium and the stagnation of the secretions, that can further lead to the secondary bacterial infections. Okay. Any immunodeficiency conditions like acquired immunodeficiency syndrome, that is HIV, polyhypogammaglobulinemia, patients on any immunosuppressive drugs, they will be having a more tendency for the development of the rhinosinusitis. Any autonomic imbalance like any emotional disturbances, any stress, thermal changes, change in the humidity, and any drug-induced rhinitis can also favor the development of the rhinosinusitis. Any hormonal imbalance and granulomatous conditions as discussed before, and any iatrogenic like surgical trauma, and it could be idiopathic, like all these things can result in the development of the sinusitis. So coming to the pathogenesis of the sinusitis. So whenever the person is exposed to any allergen, in that individual there will be a development of the mucosal congestion, or or it could be any because of any anatomical obstruction. It can cause the blockage of the airflow and the drainage. So what happens further? It will cause the secretion to stagnate, and this secretions will get thickened up, and the pH of the secretion will also change, and this can result in the change in the mucosal gas metabolism, where the cilia and epithelium are damaged, and there will also be and this will act as a culture media for the bacteria to grow within the closed cavity, which can result in the retainment of the secretions within the sinuses, and this bacterial infection develops within the sinus cavity, and this can result in the mucosal edema, and all these things will result in the closure of the ostium, and this nidus will keep on repeating, which will result in the development of the chronic rhinosinusitis. So coming to the pathology of the chronic rhinosinusitis, there you can see the epithelial hyperplasia, squamous metaplasia, increased number of the goblet cells, edema and the infiltration of the cellular inflammatory cells, ciliary damage, subepithelial interstitial fibroblastic proliferation with lymphatic obstruction, and the presence of frank polyposis. Coming to the symptoms, headache will be less severe than in case of acute sinusitis, and it is more evidence towards the afternoon, and nasal obstruction is present, which is persistent, and it is worst at night, and there will be a loss of sensation, and also cacosmia can be present, that is the abnormal sensation of the taste. And you can also have a reduced sense of smell with the presence of nasal discharge, which is viscid and mucoidal in nature, and there will be a hawking sensation in the patients because due to the postnasal drip. Coming to the signs, you can elicit the tenderness on percussion of the sinuses, and on anterior rhinoscopy you can see the presence of discharge which is coming from the middle meatus. It could be either mucoid or mucopurulent in nature, and in posterior rhinoscopy you can see the discharge coming from the middle meatus. So coming into the individual discussion, of the individual sinusitis. Coming to the chronic frontal sinusitis, the etiology and pathogenesis of the chronic frontal sinusitis is same as discussed above under the sinusitis. In elderly children, one extra factor is because of the chronic adenoid hypertrophy. So here you can see the adenoids, which can cause the obstructions of the sinuses, resulting in poor ventilation of the sinuses. Next, again the symptoms. Here it is less severe than that of the acute frontal sinusitis. It is dull aching type, and the patient experiences the feeling of heaviness of the head. Sometimes this kind of headache is referred to as office headache because it will be more in the morning and it will be reducing by the afternoon. And you can also have a anosmia or a hyposmia, which will be associated with a mucosal edema in the region of middle turbinate, and cacosmia can be experienced by the patient because of the purulent nasal discharge. Next, the patient will also experience the postnasal drip with hawking sensation. Along with that, the nasal obstruction will be present. Coming to the signs, you can elicit the frontal tenderness in case of acute exacerbations, and on anterior rhinoscopy it will reveal the presence of discharge in the middle meatus or the discharge coming from the middle meatus. Coming to the investigations, you can order for the X-ray PNS, which is of Cadwell's view or Waters view, where you can see the haziness within the frontal sinuses here. This is the interfrontal septum, and this is the two frontal sinuses, which is divided by the interfrontal septum, where you can see the opacities within the frontal sinus. And CT-PNS can also be taken with catheters and show the fluid level. And this is the CT scan of the patient, where you can see the affected sinus on the left side, which is completely opacified, or you can see the haziness within the frontal sinuses, which indicates the presence of left frontal sinusitis. And the gold standard diagnosis is the diagnostic nasal endoscopy, which will show the presence of discharge or mucosal edema in the upper part of the middle meatus in the region of frontal recess. So amongst all, the gold standard investigation for the rhinosinusitis is the diagnostic nasal endoscopy, that is DNE. Coming to the treatment, the treatment of choice is the FES, that is the functional endoscopic sinus surgery, where you can have a proper frontal recess clearance here. And nowadays, link Howard operation can also be done, but it is obsolete nowadays. And medical treatment can only just give a temporary relief, that is, it can just give the relief with the symptoms like headache, nasal obstruction, but the treatment of choice for the chronic frontal sinusitis is FES, that is the functional endoscopic sinus surgery. Next, coming to the chronic ethmoiditis, the ethmoidal labyrinth or the ethmoidal air cells, they get infected because of the anatomical or pathological abnormalities. So inadequate treatment of the acute infection with the presence of the abnormalities like anatomical abnormalities, they tend to persist within the anterior ethmoidal cells, and these cells, they harbor the chronic inflammatory focus within their mucosa, and this causes a persistent or the recurrent infection within the major sinuses. Therefore, the anterior ethmoidal air cell system within the middle meatus is considered to be the key area for the causation of the chronic sinus disease. Clinical features: due to the anatomical site and the nature of infection, it frequently involves the multiple sinuses. The combination of symptoms may be present, and isolated chronic ethmoiditis is very rare. It will always be associated with either the frontal sinusitis or with the maxillary sinusitis. Isolated ethmoiditis is very rare. Coming to the symptoms, we can expect the patient to have a headache which is dull, persistent, and it is more of pressure-like symptom. The site of headache is between the two eyes, that is between the intercanthal area. And the patient will also be having the nasal obstruction, and this is persistent with the polypodal changes, and this can cause nasal because of which it can cause nasal obstruction. The patient will also experience the hawking, and postnasal discharge is present, which can be associated with the sore throat or ear block. Signs of the chronic ethmoiditis: the tenderness can be elicited in the intercanthal area during the acute exacerbation, and on anterior rhinoscopy it will reveal the presence of discharge or mucosal changes within the middle meatus, and on posterior rhinoscopy you can see the presence of discharge in the middle or the superior meatus, depending upon the group of ethmoids involved, whether the anterior ethmoids are involved or whether the posterior ethmoids are involved. Coming to the investigations, a CT scan can be ordered, and gold standard investigation here again is the diagnostic nasal endoscopy. The disease is diagnosed as osteomeatal complex disease. In the CT scan, you can see the affected ethmoids which is being affected, where you can see the opacification within the ethmoid sinuses. Treatment, again the gold standard treatment for the chronic ethmoiditis is the functional endoscopic sinus surgery. The intranasal, external and transantral ethmoidectomies are not practiced nowadays. Laser and microdebrider can be used as a tool for the precise conservative surgery. The main aim of the FES is to eradicate the disease from the anterior ethmoidal cells and also within the posterior ethmoidal cells, and also to facilitate the drainage of the major sinuses through the natural ostia. Next, coming to the chronic sphenoidal sinusitis. The isolated sphenoidal sinusitis is very rare. It may be present as a part of pansinusitis, sometimes associated with the posterior ethmoidal sinusitis. So, isolated sphenoidal sinusitis, if at all it's present, the fungal infection can be suspected. Pathology, it is almost always associated with the chronic ethmoiditis, and it can be because of the fractures of the skull base involving the sphenoethmoids, where because of the fracture line, this can give rise to the secondary sinusitis. The fracture line will act as a route for the spread of infection within the sinuses, giving rise to the sinusitis. Symptoms here is the headache. It can be either vertical, frontal, occipital or central. The pain will be radiating to the temporal region. Post-nasal drip with hawking sensation can give rise to the throat pain. The patient can also experience the cacosmia, that is the abnormal sensation of smell, and halitosis, that is the bad foul smelling breath. And signs, the supratubal stream of discharge can be seen coming from the can be seen in the posterior rhinoscopy. Coming to the investigations, Waters view with mouth open will show the fluid level or mucosal edema. So this is the Waters view of the paranasal sinuses with open mouth, and open mouth is important to look for the sphenoidal sinuses here. These are the frontal sinuses, ethmoidal sinuses, maxillary sinuses, and with the open mouth you can see the presence of sphenoidal sinuses with intersphenoid septum here. So this will help in the diagnosis of the mucosal thickening within the sphenoid sinus, which is indicative of sphenoid sinusitis. And CT scan can also be taken. And gold standard investigation again here is the diagnostic nasal endoscopy, where you can see the discharge coming in the superior meatus or the sphenoethmoidal recess. So differential diagnosis, it could be sphenoidal mucocele or pituitary adenoma. Treatment, medical treatment is not that much effective in sphenoidal sinusitis. Antibiotics, systemic and local nasal decongestants, anti-inflammatory drugs, antihistaminics, and nasal irrigation with saline, mucolytic stimulation can be tried, but the ultimate treatment is the FES with posterior ethmoidectomy and sphenoidotomy, and endoscopic sphenoidotomy in isolated sphenoidal disease can be performed. But the gold standard treatment again in chronic sphenoidal sinusitis is the FES, that is a functional endoscopic sinus surgery. Thank you. Any doubts? Okay, the marks of the practical exam which was conducted on July 3rd, it will be announced by HOD sir after he takes the permission from principal sir. It will be shortly announced, even the answer keys also. Okay. Thank you.